name is Dr. Ashish Kishan. I'm working as a consultant cardiologist in Fortis Escorts, New Delhi. Today, I'm going to talk about the latest update in hypertension in the year 2022. As per WHO, nearly 63% of total deaths in our country are due to non-communicable disease, of which 27% has been attributed to cardiovascular disease, which affects nearly 45% of people in the age group of 40 to 69 age. Raised blood pressure is amongst the most important risk factors for cardiovascular disease. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care, and poor follow-up. As per WHO data, in last 30 years in our country, the prevalence of hypertension has gone up to 38% in men and 32% in women, respectively. Despite that, nearly 51% of men and 41% of women are hypertensive, but they are not aware of it. Additionally, 62% of men and 53% of women living with hypertension, that is that they know about the disease, do not get treated. As per the data from the worldwide, medication was used to control blood pressure in fewer than 1 in 5 men and 1 in 4 women with hypertension. International Society of Hypertension, that is ISH, in 2020 have given out global hypertension practical guidelines. The inclusion of optimal as well as essential treatment paradigms attempts to address this particular issue, especially in situations where resources are poor. Optimal care refers to evidence-based standard of care, whereas essential standards refer to minimum standards of care to allow specification of essential standards in especially poor resources setups. As far as AHA and ACC have concerned, they have released a statement in 2021 which offers a new guideline for management of stage 1 hypertension amongst patients with low atherosclerotic cardiovascular disease. Amongst the low-risk adults, wherein no atherosclerotic cardiovascular disease or a 10-year CVD risk is less than 10% with stage 1 hypertension, which includes a blood pressure of systolic being between 130 to 139 or diastolic between 80 to 89 millimeters mercury. The management starts with non-pharmacological therapy. If the blood pressure remains still uncontrolled at 3 to 6 months, considering a standard therapy of pharmacology is required. Acute respiratory distress syndrome is a potentially fatal condition which involves the damage of the lungs, and experts have associated with severe COVID-19 illness. In a recent study, as far as JAK is concerned, in 2021, a data came out with metoprolol having to reduce the lung inflammation and also improve respiratory functions in people who are suffering from COVID-19 induced ARDS. Lowering systolic blood pressure targets to 110 to less than 130 millimeters mercury range substantially tend to reduce the adverse CV event rates in the STEP randomized control trial, which did affirm the sprint trial for the findings of older Chinese population. With regard to prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, in 2018, ESC had come out with a management of arterial hypertension that recommends the diagnosis of hypertension should not be dependent on office blood pressure, but also on out-of-office measurements such as ambulatory blood pressure monitoring or homebound blood pressure monitoring. 24-hour and nighttime blood pressure measurements were also associated with greater risk of mortality and a composite of CV outcome. Thus, they may be considered as the most relevant measurements for estimating the CV risk. For every 20 systolic and 10 diastolic increment of the blood pressure measurement increment in that night, the risk of mortality increased by 23% and the risk of cardiovascular events increased by 36%. Most patients with hypertension require lifelong medical therapy to achieve optimal blood pressure control. In 2018, ESC guidelines equally recommended 5 classes of antihypertensive drugs. Considering high non-adherence therapy, the importance of the combination treatment is particularly highlighted to improve adherence to the therapy and blood pressure control. Therefore, to start antihypertensive therapy, an initial dual fixed dose combination has been recommended of ACE inhibitors or ARB with calcium channel blockers or diuretics. Since early July 2018, products containing valsartan have been recalled worldwide. The reason has been the detection of a known carcinogen name called as N-nitrosodium dimethylene, which basically was considered and been found in cardisentan, irbescentan, losartan, olmesartan, and valsartan. The NDMA has been classified by the WHO International Agency for Research on Cancer to be carcinogenic in humans, and the presence of these contaminants in the drugs would lead to additional 8 cancer cases in 1 lakh patients if they have been taking it for a daily dose for next 4 years. The HIGHGAS study represents the largest study that tested the nighttime antihypertensive therapy. In this trial, chronotherapy was associated with a significant reduction in endpoints, including death. The HIGHGAS chronotherapy tests showed nighttime therapy in comparison to the usual upon awakening hypertensive therapy. It exerts a favorable CV risk reduction. It has been the largest study, which included nearly 19,000 hypertensive patients with an average follow-up of 6.3 years, where 1,700 patients nearly experienced the primary CV outcome. An ambulatory blood pressure measurement was performed for 48 hours to collect the data on how BP differed during the sleep. The relative risk reduction for CV events was significantly improved for nighttime treatment when compared with awakening therapy. Thank you.